katogo like that because the katogo is being mixed with the cassava. Mugoyo, it is the janjalo mixed with the potato. But the kalo needs the meat and fish. It's not complicated, like it's not that. You can eat with the potatoes and you feel comfortable. But you also eat kalo with the pested.
Yes, so I'm Bob Ramadan Chirunda. I'm a copy-eye on this study about type 2 diabetes, the social norms that influence type 2 diabetes. And we started this journey in 2020 when we did an assessment in Busia and Bugiri. The principal investigator is Dr. Juliet Kiguli from the School of Public Health, who is leading a team of other researchers. We also have Dr. Roy, again from Public Health, who also has worked a lot in the type 2 diabetic area, and Professor Paul Bukuluchi, who is also a copy-eye, and he's an authority, renowned authority in terms of social norms work. Where we are now is a level at wanting to really learn more a bit about type 2 diabetes, looking at the other affected regions, that is Lango and Teso. So we have now brought these together to learn from each other, to see if what we learned among the Samia and Busoga in Bugiri and Busia is also the same situation in Lango and Teso. The idea is that we are able to scale and spread this innovation and implement it in many districts and pilot it, for maximum impact. So once we are done with this cross-cultural learning, we are going to be implementing now the intervention through the community systems. It is an experimental study. We want to generate evidence about its effectiveness, and then that evidence will inform the potential for scale and adaptability in other cultural regions of Uganda. Many development programs that want to change community normally come with the mentality of doing for the people, and many organizations also target, or they come with that idea that they are the ones to change the society. What this innovation is doing is society, the community itself, the affected community. You've seen in this learning we have religious leaders, cultural leaders, we have patients with type 2 diabetes, we have VHTs, we have health workers, because they are the ones now who are actually faced with this challenge. So it is a community-driven innovation, a community co-designed intervention, and therefore the potential for success and sustainability is high. So when we leave them with the knowledge and the tools on how to transform the norms around type 2 diabetes, then the onus is on them, because the idea is once they understand the problem, then they take action against getting themselves out of the problem, as opposed to waiting for any other organization or donor to come in. So the university is a research institution, so we are doing the research. Fidelitas is going to come in with the facilitating the implementation on the ground, monitoring what is happening, and then handle whatever comes out to the community to take forward. So it's one of the programs where I want to see you design an innovation with the community and for the community, and leave it with them to take forward and solve the type 2 diabetes problem.
I'm Dr. Juliet Kiguli. I'm the Assistant Commissioner in charge of Non-Communicable Diseases at the Ministry of Health. And we are talking about diabetes type 2. Diabetes type 2 is a lifestyle disease. It's one of the non-communicable diseases and is increasing in our population. I think the last time we did the study, it was about 3.2% of the adult population in Uganda, and we have done another study to inform us. It is increasing because of the lifestyle changes. Ugandans are continuously eating poorly. They may say that they are eating well, but they are actually eating poorly by eating processed foods, fried foods, the fast foods, the chips and chicken, the kebabs, all those things are unhealthy. They have a lot of fat, a lot of salt, and a lot of sugars. So they are unhealthy. The other factor is because they are increasingly becoming physically inactive. They are using motorized transport where they could walk. They are now using a boda. So they are not active. They come and spend the whole day seated in the offices, drive back, sit before TVs, and they go to sleep. And this has led also the problem of obesity or overweight, either obesity or overweight increasing. So really we have to act. And of course, maybe what I have not mentioned is that diabetes has very serious complications that are difficult to manage. People who have heart failure, people who have kidney failure, people with blindness, people with amputations, people with failure to elect, is because of the complications of diabetes. So it is a serious problem that has serious complications that we must address. And how do we address it? I mean, there are some proven interventions that the WHO and other agencies are advising us. But I'm happy that we are now trying to find local solutions with our partners. They did a study in Busia and Bugiri, and now they are expanding to Lango and Teso. We are happy with this study because it's going to inform us more and to give us local solutions. First of all, what are the local factors that are leading to the increase of diabetes? You may say physical inactivity, unhealthy diets, tobacco use, alcohol, but what is it in these local communities that is bringing the increase? And what are the local leaders, the stakeholders, what are they saying about it? What are they advising us? Culturally acceptable interventions that can reduce the prevalence of diabetes and other non-communicable diseases. So we are happy to learn from the local communities so that they inform us, our programming, what best works, other than just copying what works in Switzerland and in the United States may not work in Busia. So that's the reason I support this study. That's the reason I'm here. I traveled all the way to come and listen to the local stakeholders, the local population. What do they think that is causing diabetes and how best can we address it? Culturally acceptable interventions. So we are listening as Ministry of Health, and we are waiting for the report to inform our programming, our actions about this problem. I thank you.
Yes, my name is Andrew Ochole, and in the Socio-Cultural Union, and we are here today trying to find out some socio-cultural practices that impact on diabetes, that is diabetes, second type of diabetes. And this has all been brought about by the leaders in conjunction with Makerere University. This research has never been done anywhere in Teso, but we first of all like to thank them for having done that, because as we all know, the biggest drivers of this diabetes, the second diabetes type 2, are majorly our lifestyle diseases, and we are just here today to try to see how we can document those social cultural practices as the impact on both positively and negatively, and see how we can use those practices to reduce, and also on the other side, how we can use the same practices. If there are those that are bad, we need to synthesize our people and make sure that we stop those cultural practices that promote the bad lifestyle diseases that are giving us diabetes part 2. As we all know that Teso, like any other place, has had a lot of challenges when it comes to these non-communicable diseases, And this one has been a killer one, silent killer. And nobody has really been coming out to try to find possible ways, local ways of making sure that we try to bring it down. But as I've said, we thank the organization of Mellitus with the Makerere University. So we expect that after we have documented these socio-cultural practices, we intend working with the institution to try and get back to our communities down there and begin sensitizing them on the dangers of this vice, the diabetes part 2, type 2. We also need to sensitize our people on the lifestyle diseases, those non-communicable diseases as they are. And we expect to partner fully with the Mellitus and the Makerere University Institute that is helping us in trying to help our communities in dealing with this vice. So as we are here today, I know the report will come out and then we shall be able to go and disseminate to our people, because the focus majorly has been the hospital. But we have left out the social bit of it, the socio-cultural bit of it, the drivers. So these drivers have been silent. It was just very interesting today that when we met our colleagues from the other cultural institutions who are here, and we shared, a lot of drivers came out. We were able to document a lot of cultural drivers. Others were shared. Then there are those ones that are peculiar to certain regions, like for us in Teso there were those that were really peculiar to us. And we also learned other peculiar drivers from the other institutions. And I believe together we should be able to support our people really. Previously, no research has ever been done about this. This will be the first research, and we are really very grateful to the organizers of this. And I do believe it is a milestone in the right direction in helping our people against these diseases that are killing us silently. Because major focus has been on other diseases.
And most of the people, they don't know that these norms and the cultural deeds which they do, that they are also part of what? Of the risk factors. So this program actually has been so good, and it is so good, like I'm saying, because now we have been trained, we have also trained others, patients have also trained, and the patients have trained other people. They have sensitized their friends. Sensitization is an ongoing process. And we have found out that even people who are at risk, actually they have not developed diabetes. They are on ongoing checkups and they are doing well. Why am I saying so is that we have encouraged them to actually continue checking themselves. Sensitization has gone on, and actually I'm so happy that even up to today, there is a lot of mentorship, and we promise that when we go back, we are going to go and inform the people who have remained behind, and then we are going to strengthen the health education talks at the diabetic clinic and even in other clinics like outpatient, because it is the main entry in the hospital. We shall also integrate these talks of diabetes type 2 when you go out to these other existing outreaches. So I really thank Dr. Kiguli so much, who is the commissioner of this project, for having come up with an initiative to select the districts which are having a problem of diabetes 2 disease. Actually, we believe that with this continuous mentorship, we are actually going to join hands, and I believe that we are going to manage. We shall manage cases, and then those ones at risk, we are going to try as much as possible to devise means so that they learn on how to work on themselves. Why am I saying so is that in our African setting, like in Bugiri and in Busia district at large, this business of exercises is not there. Maybe for only those ones who are farmers, when they go to the gardens, they can dig, and that is exercise. Other people don't bother, they don't know the use of exercises, when actually it is one of the preventive measures of this type 2 diabetes. The feeding habits, like in Busoga, for example, because of polygamy, you find that a man overeats. Why does he overeat? Because of having so many wives. When he goes to house number 1, there is a food. House number 2. And then we have also had a business of frying everything. So we are going to teach women, apart from just diabetes itself, on how to learn to prepare foods without cooking oil. Foods which are healthy for both their husbands and their lives. Because with the food, once we change the way we prepare our foods, it will also help us to prevent diabetes type 2.
We hope to take this forward. The learning from this workshop will be shared across these 4 regions. But we want to extend this to other regions as well. This learning should go to other regions. So we are focusing on moving forward, scaling up, and making sure that we take this learning to more people than we have now at the moment. Yeah.